So welcome and good afternoon. My name is Dr. Jeffrey Gold, and I appreciate your attendance today and your interest in our topic. This is the first part of a three-part mini-series on psychedelic-assisted therapies presented by the Institute for Integrative Health and Wellness in partnership with our colleagues at the USC Center for Mindfulness Science, or CMS, and we're known as the IIHW, and researchers from the Multidisciplinary Association for Psychedelic Studies and Public Benefit Corporation, often known as MAPS. We will be having this talk about the evidence base supporting MDMA-assisted therapy for PTSD and the mechanisms behind it, and the elements behind the MAPS MDMA-assisted therapy for PTSD treatment protocols. And again, I'll be your moderator, and I'll be introducing our three presenters as we move along through our presentation today. Our format today will be three speakers speaking individually for about 18 minutes each, and then we'll go into a Q&A where you can ask any of your questions into the Q&A format. You can see the very bottom part of your screen. It says Q&A, and right there you can place any of the questions that you have for our presenters. So again, our title today is an overview of MDMA-assisted therapy for post-traumatic stress disorder, and you can see the activity code. I'll give you instructions for the EADS in 1 second. Next slide, please. Our mission at IIHW, the Institute for Integrative Health and Wellness, is to promote the health and healing of individuals, families, and communities we serve through the advancement and practice of integrative health, the science upon which it is based, and the education of the healthcare practitioners in the USC community, as well as our surrounding communities and our country. Next slide. Our vision is to transform healthcare by establishing a collaborative, holistic paradigm that promotes health and healing and integrates all aspects of human life: physical, emotional, mental, spiritual, cultural, social, and environmental. Our collaborators for this sponsored presentation today is, again, the USC Center for Mindfulness Science. It's a collaborative hub for interdisciplinary research and innovation in the practice of mindfulness. And their aim is to shed light on the science behind mindfulness so that we can better understand how this practice affects our minds and consequently our behavior. We like to present with a land acknowledgement, given that USC and also Children's Hospital Los Angeles and our communities are on ancestral lands. The Institute of Integrative Health and Wellness at USC and Children's Hospital acknowledges our presence on the traditional, ancestral, and unceded territories of the Gabrielino and the Tongva peoples. We recognize that these peoples were forcibly removed from their homelands, and we take this opportunity to acknowledge the generations that have gone before, as well as the present day Gabrielino Tongva people. With humility, we recognize and respect all Indigenous peoples, their histories, and their ties to this land. We also recognize the Chumash, the Tatavim, Serrano, Chihulia, Juaneno, and the Louisiana people and the land that USC occupies around Southern California. We pay respects to their past and their present. Let this acknowledgement serve as an ongoing reminder of the original inhabitants where we reside. So if you're going to be getting credit or CMEs for this activity, you can download the EADS mobile app, create an account for yourself, and then sign into the educational activity and enter this code, 79VAMP. So if you're going to be getting credit for that, please do that if you don't already have EADS on your system. This is the activity code, 79VAMP. Okay, terrific. That's a good start for our symposium today, or our mini series. Our first presenter today, excuse me, is going to be Allison Coker. Dr. Coker has her Ph.D. and serves as the Associate Director of Regulatory Affairs at MAPS PBC, where she guides the North American regulatory strategy to develop and deliver innovative products to marketing approval in alignment with global business strategies. Dr. Coker serves as a regulatory lead on cross-functional care teams to communicate regulatory requirements, ensure optimal execution of regulatory strategy, and study governance. In this role, Dr. Coker provides expertise, sound decision-making, and guidance, both strategic and operational, to develop and optimize the regulatory strategy across MAPS, their clinical development programs. Dr. Coker was trained as a neuroscientist with a multidisciplinary background in behavioral pharmacology, studying motivation, addiction, stress across diverse research methodologies in both preclinical and clinical research settings. She earned her bachelor's degree in neuroscience and behavioral biology from the University of California. Neuroscience and behavioral biology from Emory University, and a doctorate in neuroscience from the University of California, San Francisco. Prior to joining MAPS PBC, Dr. Coker worked as program manager for the Institute of Translational Neuroscience, a research consortium at UCSF, focused on conducting translational and clinical research to develop novel treatment strategies for PTSD and alcohol and substance use disorders. Dr. Coker is excited by both the therapeutic potential and regulatory challenges of making MDMA a medicine and enjoys leveraging her experience to support data-driven advancement of MAPS and clinical development program. So without any further ado, please allow me to introduce Dr. Coker.
Thanks so much. I'm going to share my screen. All right. So again, thank you for the introduction. I'm Allison Coker, the Associate Director of Regulatory Affairs at MAPS Public Benefit Corporation. Today, I'm going to share with you the results of the phase 3 randomized double-blind placebo-controlled study of MDMA-assisted therapy for PTSD. Let me start by noting that the safety and efficacy of MDMA-assisted therapy is currently under investigation. It's not yet approved by the FDA or other regulatory authorities. It does not work for everyone and carries risks even in a therapeutic setting. So this trial was sponsored by MAPS, a 501c3 nonprofit founded in 1986, with a mission to develop research and education around the medical, legal, and cultural contexts for people to benefit from the careful uses of psychedelics. MAPS Public Benefit Corporation is a wholly owned subsidiary of MAPS with a mission to catalyze healing through psychedelic drug development, therapist training, and prioritizing public benefit above profit. MAPS PBC is the trial organizer responsible for conducting these clinical trials and developing the potential therapeutic treatment. To give you a little overview of my presentation today, we'll review a little background on PTSD and MDMA. I'll give you an overview of our phase 3 trial design, and then share some of the trial demographics, and followed by the efficacy and safety results. So first, let's talk a little bit about post-traumatic stress disorder. PTSD is a psychiatric disorder that may occur in people who have experienced or witnessed a traumatic event. PTSD is characterized by intrusive symptoms such as intrusive memories, reliving of traumatic events, and nightmares. PTSD is also characterized by persistent avoidance, which can be of places or other triggers, and negative alterations in cognition, mood, and reactivity, which can lead to negative emotions of guilt and shame, hypervigilance, and sleep disturbances. Taken together, these symptoms dramatically impede a patient's overall quality of life, making everything from holding a job to having relationships with your family to getting up in the morning difficult. PTSD is also associated with changes in neural activity. The amygdala, which is the part of the brain that handles fear memory, often shows increased activity in patients with PTSD, and the prefrontal cortex, which plays a central role in cognitive functions such as reasoning and impulse inhibition, often shows decreases in activity. While PTSD is a serious condition with symptoms that can be debilitating for its sufferers, current treatments for PTSD are often limited in effectiveness and leave room for improvement. So psychotherapy is typically utilized as the first-line treatment for PTSD. And while there are several trauma-focused psychotherapies that have been demonstrated to be efficacious when delivered with adequate dose and duration, the impact of these treatments remains limited in real-world use due to substantial dropout, poor accessibility, and a highly variable benefit to patients. The primary pharmacotherapies for PTSD include SSRIs and SNRIs. These treatments are typically used chronically, and because they target symptoms, they're often used in combinations with other pharmacotherapies. The high side effects and non-adherence can also lead to limited effectiveness. And many patients need more than one type of treatment to reduce their symptoms, and there's a large need for improved treatments. One important model in understanding the types of symptoms that patients can fluctuate between in PTSD is the window of tolerance model. So this model proposes that The window of tolerance is the range of optimal arousal between the extremes of hyperarousal, characterized by emotional reactivity, impulsivity, and hypervigilance, and hypoarousal, characterized by numbing of emotions, cognitive dissociation, and detachment. PTSD and trauma are thought to shrink this window of tolerance, leading to rapid fluctuations between hyperarousal and hypoarousal, making it difficult to engage in therapy. Many forms of trauma-focused psychotherapy seek to expand this window of tolerance of the optimal arousal in which patients are present, grounded, and able to emotionally self-regulate so that emotions can be experienced as tolerable and their experiences can be integrated. So why are we looking at MDMA? MDMA is a stimulant-like compound that increases the activity of a group of neurotransmitters known as monoamines. So these are serotonin, dopamine, and norepinephrine. MDMA acts on the transporter pumps that are responsible for reabsorption or reuptake of these transmitters back into neurons. MDMA blocks these transporters, preventing this reuptake, and additionally causes the transporters to release more of these neurotransmitters. So these combined actions result in an increase in monoamine neurotransmission between neurons. This increase in monoamines can cause downstream effects on other transmitters, such as the affiliative and prosocial hormones of oxytocin, vasopressin, and prolactin, which are known to be involved in bonding. On a circuit level, MDMA has also been shown to decrease neural activity in the amygdala, the region we spoke about that is involved in fear memory and is often hyperactive in patients with PTSD. Coming back to the window of tolerance model, it's intriguing to speculate that these pharmacological properties of MDMA, when combined with therapy, may acutely expand this window of tolerance. The prosocial effects of MDMA may enable the patient to share their experiences, emotions, and memories with psychotherapists more freely. Clinicians have suggested that MDMA may work to catalyze the therapeutic processing by allowing patients to stay emotionally engaged while revisiting traumatic experiences without becoming overwhelmed. This could make therapy more tolerable and more impactful in addressing the traumatic memories associated with this condition. So let's talk a little bit about the design and structure of the phase 3 trials. This was a multi-site international trial with 15 study sites across the US, Canada, and Israel, and with 70 therapists. The trial specifically studied patients with chronic PTSD for 6 months or more. Participants were randomized to one of 2 double-blind treatment arms, MDMA administered as an adjunct to therapy, or inactive placebo delivered with the same therapy. The primary outcome assessment was the clinician-administered PTSD scale based on the DSM-5, as we call it, the CAPS-5. This is considered the gold standard of assessment of PTSD symptom severity and was selected with the FDA to support the development of this treatment for a PTSD indication. The CAPS-5 is assessed in a clinician-administered interview involving detailed assessment of symptoms. So to minimize bias in these assessments, they were conducted by an observer blind raters in a centralized pool via telemedicine. These raters were blind to the study design, the number of sessions, the assessments in the study, and each participant's treatment assignment and their visit in the study. So our study site screened a large number of participants for potential eligibility to get to the total sample of 90 participants that were in the phase 3 trial. I want to take a moment to share some of the demographics for these participants. Though a chronic PTSD diagnosis only requires symptoms for 3 months, and our trial criteria was 6 months, the study population had symptoms for 14 years on average. The population was 65% female, which is in keeping with previous research showing that the lifetime prevalence of PTSD is about twice as high in women than men. And the population was 77% white. While white patients were overrepresented in the study in comparison to the ethno-racial diversity of the PTSD patient population, MAPS PBC identified targeted measures that improved enrollment diversity in this study compared to earlier phase 2 studies. And now in our current studies, we've fully implemented these successful interventions to help facilitate enrollment of a more diverse patient sample in our current and ongoing studies to better represent these populations. The vast majority, 84% of participants had childhood trauma, and 91% had comorbid major depressive disorder. 92% reported experiencing suicidal ideation in their lifetime, and at baseline, 34% reported active suicidal ideation. While PTSD is often thought of as specific to combat-related trauma in veteran populations, our study sample included participants with a broad range of principal causes of their PTSD, with the most prevalent in our sample being sexual assault or sexual trauma, accounting for 40% of the participants in our study. Let's take a moment to review the phase 3 trial design and treatment time course. The trial consisted of a total of 3 MDMA-assisted therapy sessions over the course of about 14 weeks. After completing informed consent, potential participants underwent the initial intake, screening, and eligibility assessment. This included a review of their medical and psychiatric history, current medications, and baseline assessments. Initially eligible participants began a series of 3 preparatory therapy sessions. These were 90-minute non-drug sessions designed to help establish the therapeutic relationship and prepare the set and setting for experimental sessions. This was followed by the first experimental session in which participants received either blinded MDMA or placebo during the approximately 8-hour session. Each experimental session was followed by 3 integration sessions to integrate and process the participants' experience in the experimental session. Our next speakers will provide a lot more context and content for these therapy sessions. The series was repeated twice for a total of 3 experimental sessions with MDMA or placebo separated by 3 to 4 weeks, and a total of 12 non-drug therapy sessions over the 14-week trial. The outcome assessments were collected at baseline prior to the first experimental session, and the final outcome assessments were collected 8 weeks after the last experimental session. All right, now we get into the data. So as we discussed, the primary outcome assessment here was the CAPS-5, which is considered the gold standard scale for the assessment of PTSD symptom severity, with a score of 35 or greater representing severe PTSD, which was the eligibility criteria for our trial. A 10-point decrease in CAPS-5 was defined as clinically significant. As you can see here, MDMA significantly reduced CAPS-5 total severity score from baseline to the primary endpoint, which was 18 weeks after baseline and 8 weeks after the last MDMA-assisted therapy session. While participants receiving placebo therapy also exhibited reductions in CAPS-5 scores, there was a highly significant difference between treatment arms, with the MDMA-assisted therapy group demonstrating significantly greater reductions over the placebo therapy group. The mean change in CAPS scores from the baseline to this primary endpoint in participants completing all 3 sessions was 24.4 points in the MDMA-assisted therapy group, compared with 13.9 points in the placebo therapy group. At these same time points, the study also assessed a key secondary measure of clinician-rated functional impairment as measured by a modified version of the Sheehan Disability Scale, labeled here as SDS. The SDS measures functional impairment in areas of work, family, and social life. MDMA also significantly reduced SDS scores from baseline to the primary endpoint, with a significant difference between treatment arms in the group receiving MDMA or placebo. We also looked at several self-reported exploratory endpoints in the trial at both baseline and study termination. MDMA-assisted therapy significantly reduced depression symptoms as measured by the Beck Depression Inventory. While mean baseline scores on the BDI were in the low 30s, representing severe baseline depression. At study termination, these scores decreased by an average of 19.7 points in the MDMA-assisted therapy group and 10.8 points in the placebo therapy group. We also used the Alcohol Use Disorders Identification Test, also known as the audit, which is a self-report measure designed to assess hazard alcohol consumption that may be indicative of alcohol use disorder. In this subclinical population, we saw a small but significant decrease on the audit, suggesting that MDMA-assisted therapy may support improvements in alcohol use, which is in keeping with a recent publication from another group looking at this indication specifically. Finally, as it's critical to evaluate efficacy and safety together to assess the risk-benefit ratio of clinical interventions, I want to share some of the key safety findings from the trial. Overall, the adverse events were transient and not serious. In this trial, we defined adverse events as related to MDMA, which we term adverse reactions, when they occurred in twice as many participants in the MDMA group as the placebo group. So based on this assessment, the most common adverse reactions, which occurred in more than 15% of participants, were muscle tightness, decreased appetite, nausea, sweating, feeling cold, pupil dilation, and restlessness. These reactions were typically mild and resolved with a median time of 1 day. In this study, there were 2 participants in the placebo with therapy group who reported a total of 3 serious adverse events, or SAEs, which were of suicide attempt and suicidal ideation resulting in self-hospitalization. There were no SAEs reported in the MDMA-assisted therapy group. In this study, we also paid special attention to a subset of adverse events of special interest called AESIs. These included AESIs related to suicidal ideation that reached a specific severity criteria. In the trial, the AESIs related to suicidality were experienced by both treatment groups, with 7% of the participants in the MDMA-assisted treatment group and 11% of the participants in the placebo with therapy group reporting these events. We also looked at AEs with symptoms that may be potentially associated with a cardiovascular event, such as irregular heartbeats or palpitations, to assess if they were indicative of a clinical cardiac concern. Here, we did not observe any events in the MDMA-assisted therapy group, and they occurred in about 2% of participants in the placebo group. To assess signs of MDMA abuse potential, we looked at specific adverse event terms related to abuse, misuse, and diversion, with examples such as dependence, intentional product misuse, and drug diversion. In this clinical trial, no AESIs related to abuse potential were observed. So overall, this phase 3 trial showed positive efficacy and did not demonstrate any serious safety signals. Our next steps are to assess the durability of effectiveness in our long-term follow-up trial and to complete a second phase 3 trial to provide confirmatory evidence in order to demonstrate substantial evidence of effectiveness. Both of these trials are ongoing, and we're excited to see and share the data when it's available. Lastly, if you would like more information about this trial, I encourage you all to seek out the full publication in Nature Medicine. It's available as open access and includes links to both the study protocol and the treatment manual on our website. Thank you.
Excellent. Thank you for the kickoff. That was terrific. It's nice to see the rigorous methodology, the design, gold standard instrumentation, and the results. Very promising. So thank you for that kickoff to our mini series today. Wonderful. All right. I am going to introduce our second presenter. Please welcome Dr. Dimitri Perivoliotis. Dr. Perivoliotis, as a PhD, has been involved in mental health treatment and research for the past 22 years, with a focus on developing innovative applications of evidence-based psychotherapy for improving quality of life in people with psychosis. He currently is an associate professor of psychiatry at UC San Diego and a staff psychologist at the VA San Diego healthcare system, where he manages an award-winning mental illness clinic and training program. We actually already have a question in our chat, which we'll get back to later, about psychosis and MDMA. Along with Aaron Beck, we all know Dr. Beck, and colleagues at the University of Pennsylvania, Dr. Perivoliotis developed a new CBT intervention for promoting recovery in people with psychosis who struggle with negative symptoms and daily functioning, which is outlined in the book, entitled Recovery-Oriented Cognitive Therapy for Serious Mental Health Conditions, published by Guilford. In recent years, Dr. Perivoliotis' professional focus has been shifted to psychedelic science, and since 2018 has served as an adherence rater, and since 2020 as lead US adherence rater for MAPS phase 3 randomized control trial, which we just heard about, of MDMA-assisted therapy for PTSD. In this role, he reviews sessions, recordings for adherence to the protocol, and has helped train new raters. Dr. Perivoliotis conducts ketamine-assisted psychotherapy for veterans with treatment-resistant depression and PTSD at the VA, and also serves on a work group that's working to develop and standardize this type of treatment. He has co-founded the UC San Diego Psychedelic Science Group and has presented on psychedelics for mental health to national and international audiences. So without any further ado, I will pass the mic over to Dr. Perivoliotis.
Thank you so much, Dr. Gold. I appreciate it. And thank you, Allison. So let's get started here. All right. Thank you all for having me here today. I'm glad to be here. I'm going to be, now that we've seen a little bit about the data behind MDMA-assisted therapy for PTSD, my portion of the talk will be hopefully to give you a little bit of a better flavor for what actually happens in the therapy itself. So starting off with the preparatory sessions that Allison mentioned that begin the therapy and happen before we even administer any MDMA. There's 3 of these, and the purpose of these 3 sessions are generally to prepare the person for a therapeutic process and to obtain a fully informed consent. It's really important here from the beginning to help set a setting of safety, alliance, rapport. They're going to be doing some pretty intensive work with these 2 therapists over the course of the next few weeks. So that all begins in the preparatory sessions. There's a discussion, of course, about the person's trauma or traumas, their history, what triggers the traumatic symptoms, what has happened, the aftermath, what has happened since then, how it's affected their life. And a lot of education is provided about MDMA, how it feels, what its effects are, what the research findings are, what the study protocol is, and how the therapy unfolds. And all this is done to really orient the person into the therapeutic approach, the logistics, every really detail is covered, and also the agreements. And one of the agreements involves the use of therapeutic touch, which I will explain in a moment. The therapists also introduce in the preparatory sessions core concepts, and one of them is this concept of an inner healing intelligence. And the idea here is that we all have an innate drive toward healing, and we just have to create the right conditions for that drive to take effect and to unfold our healing process. So sometimes therapists might use a metaphor of a wound, for example. You know, the wound will naturally heal itself if you clean it, take care of it, create the right conditions. So what I really like about this, I think, beautiful concept is it's implicitly hopeful and recovery oriented. And the message is that the drive toward healing is in the person. It's not really coming from the therapist, that there's to support and help create the right context for it to come out, but it's really coming, the healing is coming from the person themselves, which I think is just really lovely. Now, part of that is trusting that that process will happen. And this includes both the participant, but also for the therapist. We as therapists trust that the inner healing intelligence will determine the right course of action for each person. For example, that the trauma will come up at some point. The therapists are allowed to bring it up if it doesn't come up by a certain point, but I've never seen that happen. It always comes up, it seems. And that the trauma will come up in whatever way it needs to. So there's this really kind of implicit trust that both the therapist and the participant practice. And to me as a therapist, having worked with people with trauma and PTSD, is this kind of liberating, because you don't feel that sort of pressure that we feel sometimes to kind of, quote, fix the person. You're there to support the process and of their own inner healing coming out. So that's one of the several concepts that are introduced in the preparatory sessions. Safety measures are discussed, for example, hydration during those MDMA sessions, because those are 8 hours long, not getting up too abruptly from the couch or the futon. There's a discussion of the therapist's background and their role, and that, for example, they're there to support the person and anything they need. Cultural factors are discussed and really put on the table. For example, if there's differences in culture between the therapist and the participant, that's really spoken about, and how that might influence the process. And the therapists work with the participant to identify a stress inoculation or emotion regulation technique that they can use if they get overwhelmed, particularly when the MDMA onset is happening. Oftentimes it's things like diaphragmatic breathing, grounding strategies, things like that. And they practice it with the participant so that they're ready to use that if needed. Similar to what you would do in other more traditional trauma therapies like EMDR, and prolonged exposure and CPT. There's a discussion about the social supports, who is available in the person's life. Is this somebody that they can lean on to some degree for support? What that would look like? Do they feel comfortable? Is it safe to disclose to them about their trauma and their trauma therapy, all those details? And if there is somebody that's appropriate, there's a possibility for them to join part of the or a whole preparatory or integration session, or possibly even the end of one of the MDMA sessions, if the therapists have vetted them beforehand. A lot of encouragement for them to discuss their needs. Therapists will say things like, this time is for you, we're here for you, this is all for you. Talk about any fears or concerns they might have, questions they might have. So you have 3 of these sessions, each 90 minutes. So there's ample time to hopefully allow all of that to happen. So moving into the MDMA-assisted sessions, this is a picture of what a typical session setting might look like. This is Bruce Poulter and Marcella Otalara, who are master therapists and the 2 people that trained me in this approach. A few things to cover here. This is broad brushstrokes. By the way, you can read more details in the therapy protocol manual, which is available on MAPS website. First off is making sure that we have a safe setting and the right setting for healing. So part of this is setting up the room in a very thoughtful way. It's more of a living room environment versus a sterile clinical office. There's a place to sleep, a couch or a futon usually, fresh cut flowers. The person can bring in personally meaningful objects, art supplies, things like that, that would make them feel more comfortable, safe, and supported. Always being mindful of culture in the decor of the office, for example, having art and symbols that reflect various cultures, not just the dominant culture, that are non-offensive, for example. There's food and hydration available for those long MDMA sessions. And in the context of the therapy, the treatment studies, there's a certain safety equipment like blood pressure monitors that have to be there as well, as safe as required by the DEA, things like that. In terms of the therapists, there's 2 therapists. It's a dyad, and they're there to support the person's process rather than direct it by driving an agenda. The latter is often the case in some of our traditional therapies, where there's very prescriptive. These are the things we're doing today. Here's the agenda I'm bringing to you. Here, it's more of it's a different approach. We're there to support and not really direct. Doesn't mean the therapists are inert and don't do anything. They actually do quite a lot of things. One is being very empathic, providing empathy, rapport, a welcoming stance, a kind of a mindful presence. Practicing empathic attunement, which is being closely monitored to the experience that the person's having, both when they're speaking, but also when they're inward and delving into the experience of MDMA silently, where they're very closely attunedly monitoring them and responding to them, and not imposing their own kind of interpretation, but really trying to be in tune with what's coming up for them. It's pretty intense work, so it's very important for the therapist to work effectively as a team, as you might guess. And again, paying attention to cultural factors, being really mindful of and mitigating power imbalances between the therapist and the participant, avoiding microaggressions like you would do in any well-done therapy, recognizing the impact of intergenerational trauma, systemic oppression, and identity-based violence, and all of that. You know, the work is pretty intensive, especially those 8-hour sessions. So the therapists it's very important for them to take care of themselves. Self-care becomes particularly important. It always is, but particularly here. Another key principle that we strive for in the therapy is something known as inner direction. And the idea here is that the emphasis is on the therapist supporting the person to have an inner experience while on the MDMA. This is thought to be an opportunity to connect with that inner healing intelligence and to really just follow its lead. So the therapist and the participant are both kind of strive toward this beginner's mind approach, being open and curious and not being tied to a particular outcome. So the therapists do facilitate inner direction in a number of ways. One way is by inviting the participant rather than directing them to periodically go inward. They may say this may be a good time to go inward if they're noticing something particularly strong is coming up for the participant. They might offer eye shades. I forgot to mention there's also therapeutically intention music playing throughout these MDMA sessions. So they may offer eye shades and headphones so that the person can really focus on that inner experience more if they would like to use those things. And the therapist, when the person is inward, are really present, but again, not leading it. Sometimes they do have to step out of that and be directive and lead it to preserve safety, the therapeutic container, and professional boundaries, of course. So these inner periods are balanced with periods of going outward, where the person might take off the eye shades and the headphones and actually have an interaction with a therapist. And during those phases, the therapist might use gentle inquiry, like what's coming up for you now? Is there something that you're noticing in your body? And if the person doesn't want to have a very verbal process, that's okay too. They're allowed to, sometimes there's long periods of silence with periodic checking in. Another thing that's important to strive toward in the therapy is being present. So here the participants are coached to, and also they're coached directly, but also the therapists model this to allow the therapeutic process to unfold, to be curious and open to what's coming up, both the positive things, because MDMA can have positive effects, lightheartedness, positive feelings, warmth, but also the difficult and painful things. It can be extremely difficult and painful sometimes, and just being really open and leaning in. So this probably sounds familiar. It's very much along the lines of what we might see in mindfulness-based approaches, third wave approaches, acceptance and commitment therapy, for example. And the participant, as I mentioned, is encouraged and invited to look at the potential value of going into and sitting with those difficult experiences, because they may be coming up for healing. So to me, this is akin to an exposure process. But what I've noticed in watching these sessions is that it feels like a kind of a more organic and self-directed exposure process than you might see in more traditional psychotherapies like prolonged exposure. And the therapists during this process convey total acceptance, normalize what's coming up for the person, even if it's something seemingly out there and unusual. They're really warm and empathic. They're just cheerleading them on the whole time and being in their corner. It's a very strong alliance, and providing periodic reminders and encouragement, such as this might be coming up for healing. As you all probably know, psychological states and trauma often manifest in the body. So the therapy really makes room for this, and it addresses somatic processes in a number of ways. For example, the participant might be invited to pay attention to what they're feeling in their body, that might go along with emotions, beliefs, or memories, or they might feel stuck and not know what's going on. And the therapist might cue them to checking in with their body as a possible way to facilitate that inner direction. And the body can be used in various ways to process the trauma and to release difficult sensations or emotions like anger and sadness. For example, nurturing touch. So in the preparatory sessions, there is a very explicit discussion around touch, that sometimes some people find it beneficial to have therapeutic non-sexual touch. For example, a hand on the shoulder or having your hand held. And the participant is asked if they would like that or if they would prefer not to. So there's an explicit consent obtained there. And there's also other things too, for example, a word that they can use if they wanted to stop. So this may be used depending on the participant and their preferences. Body work might be used too. They might be invited to push against a pillow. I've seen participants will get up and run in place, do push-ups to kind of move through stuck energy or emotions that come up. And finally, of course, maintaining safety is paramount throughout the whole process. The therapists remind the participant that MDMA the experience can come in waves. It's not really linear always, that if they're having an anxious reaction, particularly when it's kicking in, to remind them to use that strategy that they practiced, helping them get up from the couch or the futon, reminding them to eat and hydrate, and any other study protocols, for example, heart rate, measuring heart rate and blood pressure, and that kind of thing. So now that we have a sense of how the therapy unfolds, I thought I'd share with you the various ways that I've noticed healing manifest in these MDMA sessions based on my viewing and rating of sessions. One is, as you might guess, that participants often revisit their trauma, and sometimes quite intensely, and discuss the event, the traumatic event, to varying degrees of detail, and its aftermath. And it seems to happen quite organically with not a lot of prompting from the therapist. It's really fascinating. They seem to be able to discuss these painful material, sometimes for the very first time. They will often display new insights, expanded perspectives. Like, for example, they might have a sense of self-compassion, forgiveness toward themselves, even toward the perpetrator, lessening self-judgment. And the therapist might gently support and bring this out by using gentle inquiry, similar kind of to what we might see in CBT with guided discovery. But typically it's very minimal, and it seems to happen fairly spontaneous. This cognitive restructuring, if you want to use a CBT term, tends to happen fairly spontaneously with not a lot of direct kind of cognitive intervention. They may have, as I mentioned earlier, positive, affirming, light-hearted experiences, pleasant memories, a humor, little banter that might happen with a therapist in the middle of like a very difficult period. And those are just as valuable to healing. And since MDMA can induce a non-ordinary state of consciousness, sometimes you'll see transpersonal experiences. So these are things such as spiritual experiences that are outside of our usual sense of self, and can be really powerful in shifting, in moving the person's healing along. And these are welcomed, they're normalized, even if the therapist or the participant don't fully understand them. They're processed and seen as a part of healing. Along those same lines, multiplicity will show up sometimes. MDMA can raise awareness of different parts of our psyche, and this is welcomed as a natural part of the healing and also worked with by the therapist. For example, I have a particularly memorable session I remember where a veteran was really struggling with what he called his warrior part. It was an important fundamental part of who he was. It was cultivated over years of the military, but at the same time, he was terrified of it because of the violence it was capable of. So a big part of the sessions was figuring out how to integrate this warrior part. And since this is a pretty intense therapy and there's a lot of hours with the therapist, transference toward the therapist can be magnified. So this is, again, treated as normal and welcome and worked with. And the same time with countertransference, therapists have to be really mindful of their countertransference too. So one example that comes to mind is a participant with a child abuse history. They're really bonded with the female therapist. And she said things like, you know, you look like you would be such a great mom. I'd love to have a mom like you. And the therapist said, you know, I'm not your mom, so clear about the boundary there, but I would be so proud to have a daughter like you. I think it would be just amazing. You're a lovely person, you know, and it was just such a beautiful and healing moment and a good example of how transference and countertransference can be used to therapeutic benefit. And finally, as I mentioned, the somatic manifestations that can come up. I mentioned about the different things that I've seen, and it's nice to see that the therapy welcomes that, allows it, encourages it. So there's a lot of flexibility here to support healing and however it comes up for the person. This is a couple of quotes from participants in the MDMA-assisted therapy for PTSD studies that I think put color on what we just reviewed. I keep getting the message from the medicine, trust me, when I try to think, it doesn't work out. But when I just let the waves of fear and anxiety come up, it feels like the medicine is going in and getting them, bringing them up, and then they dissipate. Without the study, I don't think I could have ever dug down deep. I was so afraid of the fear. And finally, a word on these integrative sessions. These are the 3 sessions, 90 minutes each, that happen after each of the MDMA sessions. The purpose of these is to translate the experience from the MDMA sessions into meaning-making, enduring change, hopefully, and to support the person's ongoing process of healing. These are kind of open-ended discussions, exploration with some minimal guidance by the therapist. Relative to the MDMA sessions, they look more like normal therapy sessions. So, of course, we discuss the content of what happened in the MDMA sessions. The therapists have notes that they might use to cue the participant. They're invited to share any stuck points, emotional distress, cognitive dilemmas that might be lingering, positive experiences, affirming experiences, insights that they developed are validated, maybe fleshed out a little bit more. There's a discussion about how can we take all this and implement it for healing in your daily life, preparing them that the process will still unfold for days, sometimes even weeks, and it's not necessarily linear. And part of that is also being gentle with oneself, not having too many responsibilities, making big decisions, and knowing what can they do to support their wellness. You know, maybe they go for walks or practice yoga or whatever it may be, spend time with their dog or their cat. There's a really good discussion about social support, what that would look like, who that person might be. And then, of course, when you're winding down, there's a good discussion about termination and what's next for them. In the sessions that I viewed, a lot of people seem to have a therapist that they return to, but of course, that will vary. So thank you so much.
Thank you so much, Dimitri. That was just excellent, honestly. Yeah, you really provided an excellent framework. I was looking through some of our attendees, and there's many colleagues and friends and community-based therapists, hospital-based therapists, I think, and a number of questions popping up that we'll get to after our third and final presentation. But that was excellent. Thank you very much. That was terrific.
My pleasure.
All right. Okay, it's my pleasure to introduce our third and our final speaker today. This is Shannon Carlin. She has a master's and also a licensed master family therapist and is the Chief of Therapy Training and Supervision at MAPS PBC. As the Chief of Training and Supervision, Shannon leads the development and implementation of clinical training and supervision programs that prepare clinicians and counselors to deliver MDMA-assisted therapy in approved clinical settings around the world. Shannon has served as a co-therapist on MAPS-sponsored phase 2 trials researching MDMA-assisted therapy for anxiety associated with life-threatening illness and MDMA-assisted therapy for severe PTSD. She currently works with clients in a small private practice delivering transpersonal approaches, psychedelic integration, and ketamine-assisted psychotherapy. Shannon's previous professional experiences include the development of community programs, delivering resources and training for healthy living, life skills, employment, and positive youth development. Her work has served adults with schizophrenia, bipolar, and substance use disorders, families and youth in low-income residential settings, and high school students learning about moderation management of drug and alcohol use. Shannon is passionate about addressing homelessness, and she volunteered with housing projects and shelters and completed a farm internship. Just want to make sure people heard that, farm internship with the Homeless Garden Project. And Shannon received her master's degree in integral counseling psychology from CIIS, or California Institute of Integral Studies, and a bachelor's degree in cultural anthropology from UC Santa Cruz. She's an adventurer at heart and can be found in nature, gardening, and running and dancing. So thank you and welcome as our third and final speaker today. We all look forward to hearing from you.
Thanks, Jeff. It's great to be here. I'll share my screen. Okay, great. Thank you for having us, and thank you, Allison and Dimitri. I'm going to continue the thread with following up on ethics, culturally informed care, and the future. So I just want to continue weaving in what Allison and Dimitri have shared, that really the framework from our phase 3 publication, the pharmacological properties of MDMA in combination with therapy, producing a window of tolerance, which participants are able to revisit and process traumatic content without becoming overwhelmed or encumbered by hyperarousal and dissociation. MDMA-assisted therapy may facilitate recall of negative or threatening memories with greater self-compassion and less PTSD-related shame and anger. And to share another quote from a participant, I had been launched onto another plane of connection to what it means to be a human being, the joy, the sorrow, all of it held with the grace of gratitude and acceptance. And I just want to move into ethics and say that these, hopefully positive impacts that this one participant shared is really predicated on the safety of the therapeutic container and the ethical practice of the therapist. So to extract some of what Dimitri shared from the interdirected approach, as well as it being a theoretical orientation, it really is an ethical foundation for this work. The interdirected approach emphasizes invitation and curiosity, and it places the source of growth from within the participant, supported by the therapy and the therapist, but not sourced from the therapy and the therapist. So therapists are following and supporting the participant's unfolding experience. Their job being to create and maintain the safe therapeutic container and allow the participant to have as much space as they're willing to express their experience and be present with it, and to step in when needed to be more directive if a participant is experiencing overwhelm or stuckness or uncertainty, and also to continue to uphold the safety and professional boundaries. So therapists discuss a theoretical approach with participants at informed consent and during preparation and throughout the treatment, and really invite participants to engage in the concept in a way that makes sense to them in their own words and perspective. And that does support, a culturally informed practice, as well as an ethical practice of centering the client so that the process of meaning making and value is coming from them rather than imposed by the therapist. So I want to highlight there are inherent power dynamics in any therapist-client, doctor-patient, researcher-participant relationship. On top of that, there can be unique power dynamics in working with non-ordinary states of consciousness and psychedelic substances. The effects of a non-ordinary state of consciousness could translate to, depending on the substance and the experience, different capacities and levels of vulnerability, such as tracking what's happening in the room or one's sense of time passing, or the quality of communication. And also particular effects of specific psychedelic substances. So for example, MDMA has the potential to increase suggestibility, fear extinction, or prosocial behavior, which could result in a participant wanting to align more closely with a therapist or having more positive feelings about a therapist. And in many ways that supports, we believe, the therapeutic action, that the therapeutic relationship and rapport can be stronger and developed quicker. But again, that means that therapists have an even greater responsibility for ethics, for care to safety, boundaries, consent, as well as self-awareness. And it's really where the focus on collaborative decision-making with the participant and an emphasis on client-centered approaches serves this, mitigating this power dynamic. I want to mention one or two things in kind of going a little bit further with some of the pieces that Dimitri shared about the modality. One is that we respect protective mechanisms. So not only inquiring and referencing the participant's experience and avoiding interpretation or assumptions, but also when protective mechanisms come up, we respect them. So protective mechanisms play an important role in our psyches. They help us get through times of overwhelm and acute periods of stress. The problem is when they continue to be employed even well after the threat of danger is present, which, as we know, is a common feature of a trauma response. So it's very common that resistance and protective mechanisms come up in any kind of psychotherapy. And when those come up in the MDMA-assisted therapy, the therapist really approach it and invite the participant to approach protective mechanisms with curiosity. So learning, what is the role of this protective mechanism? When did it get its job? What need is it attempting to fulfill? And are there other ways that we could fulfill that need so it doesn't have to work so hard? It can be tempting sometimes when resistance or distraction comes up to want to kind of bulldoze over that or try to exile it or suppress it or bury it. But really, we say that needs to be worked on in and of itself before the rest of the therapeutic process can continue. And I thought I would just highlight, because there's different conversations about, interdirected and non-directive, and some of these terms are borrowed from Carl Rogers' client-centered therapy. And so it's not a passive stance. And also the therapist shouldn't be interjecting themselves and their personality into the participant's experience. So it's this dance. And really the optimum level of interaction is the amount that allows the therapist to track the participant's experience, demonstrate empathic presence, and develop and maintain therapeutic alliance, while allowing the participant to engage as fully as possible in their unfolding experience with minimal interruption or distraction. Sometimes that looks like a lot of interaction, talking or interaction between a participant and a therapist. Sometimes that looks like very little talking. That can change from hour to hour in the session. The sessions are 8 hours long. That can change from session to session within one participant, and also different participants can have different styles and reactions. So that just leads us to an ethical framework. So in 2019, MAPS published a psychedelic psychotherapy code of ethics. And the reason that we did that was because of these unique ethical considerations that deserve to be trained on and to be talked about explicitly. And they kind of go above and beyond what our research ethics with our IRB and our medical and psychotherapy ethics dictate our professions. And so we wanted to be really explicit with therapists coming through our training program and working on our training program, working on our clinical trials. So of course, safety first. I'm only going to highlight a couple of the 12 tenets of the Code of Ethics, but it is available on our website at mapspublicbenefit.com/training. I'm sure we'll send you those links later. So safety, this is really a multidisciplinary approach where medical professionals and mental health professionals need to work together. And so they each work within their scope that the medical professionals are assessing medical eligibility and history, screening, contraindications, and overseeing the medical safety of participants throughout the course of their participation. And mental health professionals are doing psychological assessments, maintaining psychological safety in sessions, and conducting the sessions themselves. So preventing immediate harm or injury. MDMA can sometimes cause dizziness. And so we want to support people, for example, when they get up, stand up, and need to walk to the restroom. And so that's really held with a lot of thoughtfulness. So for example, on informed consent, when the therapists are going over informed consent with the participant, they'll describe that that is one form of physical contact that's essential for participating in the protocol, that if the participant has to use the restroom, we're going to ask them to sit on the edge of the couch and put their feet firmly on the ground. And that if one of the therapists is going to support the weight of the participant with just one of their arms by placing a hand on their elbow and on their arm to support some of their weight. And then they're going to walk to the restroom with the participant and stand outside until the participant exits the restroom, and then help support them in walking back. So just being really specific about what we're talking about in terms of what procedures might be included, especially around touch, but really about any kind of intervention, the therapeutic orientation, and then any kind of procedures that are taken. Checking vitals is another place when blood pressure needs to be checked. It's pretty difficult to avoid some kind of physical contact when you're putting a blood pressure cuff on someone. So those things, the more specific of those are, the clearer informed consent can be, and it's also a trauma-informed practice too. So other forms of safety, especially in working with psychedelics, are thorough preparation and integration. We can't know what all will transpire in the participant's internal experience during a session, but we can prepare them as best as possible to deal with any experiences that could come up. So there could be joyful experiences, as Dimitri was saying. There can be challenging experiences. So we talk about what might those look like, what are some common subjective effects of the drug, and then making sure that we're really spending a lot of time in integration afterwards. And there's a lot that we do know, like we do know what the structure of the session is going to be and what the boundaries are going to be and what the process is going to look like, even if we can't predict exactly what the participant's internal experience will be like at a given session. It's also important to address participants' concerns or anxieties at any point, at informed consent and also at any point. to really make sure that there's a safe space for participants to be invited to share concerns or anxieties, whether it's about the substance or the experience or the therapy or the therapist or the therapist relationship or anything. People can have concerns about the kind of music that's going to be played, which is also a conversation therapists have with them during preparation. So we want to get a safe space so participants can get that all on the table and talk about it well before going into their experimental session. That all really weaves into informed consent, and I'm not going to go in detail into each of these standard practices of informed consent apply here, including informed consent for participating in a clinical trial. But what I really want to emphasize is the process of consent, continuing consent, and options for participants to withdraw consent, which is important, of course, in any therapy or clinical trial. And we really emphasize that with our therapists and how they're checking in on consent, throughout the process. And especially Dimitri mentioned physical contact, which I'll get to in just a moment. As I said, laying the foundation for integration and termination. So the participant's therapeutic process will continue to unfold for possibly hours and days following the session. And it's important for participants to be aware that that could happen so they're not caught off guard. And what that can look like is ongoing reflections, feelings, thoughts, or memories that continue to unfold after the session. Participants may feel open or sensitive for a period of time. And so the therapists work to prepare the participant for this and to identify resources and practices the participant can engage in if those experiences come up for them. For example, diaphragmatic breathing or another stress inoculation technique that works for that participant. And we really encourage people to be gentle with themselves around the days following the therapy session. I just want to highlight one or two things. So a lot of, like I said, our code of ethics is going to look very similar to mental health professional codes of ethics. And then we just place we really emphasize the importance of some of these aspects. When you're in an 8-hour therapy session with deep trauma processing of an investigational substance and a non-ordinary state, there's a lot going on there. And it's really important that therapists have a good handle on maintaining the therapeutic container and that participants know what that means and what to expect from the therapist. We also, because people are in non-ordinary states and we talked about the potential for greater suggestibility, want to continue just placing the census of power, using the therapist role power for the participant and continuing to refer to the participant's inner experience to guide and direct and interpret what is happening for them. Dimitri mentioned, sometimes somatic experiences can come up as part of trauma processing. They can also come up organically and spontaneously in non-ordinary states. So in order to practice ethically, therapists should have some competencies around what are somatic manifestations of trauma, what kinds of somatic experiences might show up in MDMA-assisted therapy sessions for PTSD, and what are some ways of working with participants around that. So there's many ways of working with that. Participants should be prepared and informed that somatic manifestations can happen and what that means. So for example, if somebody's going through a moment of trauma processing, they might have some spontaneous shaking of their chest happening or shaking of their arms. And so we would talk about that with the participant, that you could have parts of your body that move. And the therapist's role is to make sure that that movement is safe. So for example, the participant isn't at risk of hurting themselves or other people, in which case they would make an adjustment and ask the participant to make an adjustment in their movement. But really that somatic experience is seen as part of the process and is included and welcomed as part of that process. So therapists can support the participant in engaging with that within themselves. And then Dimitri also mentioned touch. So as I said, there is a certain kind of touch, safety touch, that is essential for participating, which is to prevent imminent danger or injury. What's always optional is nurturing touch, such as a hand to hold, which would need to be fully consented, including a description of why would that touch even be considered, and on what parts of the body would that touch include or not include, how would that be requested by the participant and consented, and how would the participant know how to withdraw their consent for that at any time. And as Dimitri said, some participants have said that being able to ask for a therapist's hand to hold were really important moments in their therapeutic process, to be worthy of care and to find some grounding. And of course, the converse is true. Unethical and unsafe practices of touch have great potential to cause harm, which is why being really specific is not only a trauma-informed approach, but an ethical approach. I'm going to move forward and ask for, I hope I can still have 3 minutes because I would like to get to the next section. So yeah, I'll just move there. So Kylia Taylor wrote a book called The Ethics of Caring, and she's worked with non-ordinary states and ethics of people, professionals working with psychedelics and other non-ordinary states. And really that psychedelic sessions can open up powerful emotions, not just for participants, but for the practitioners. Like I said, an 8-hour therapy session, deep trauma processing, non-ordinary states, it is a lot to hold. And so that's why the emphasis on therapeutic alliance, relationship, and transference and countertransference awareness is so essential. And I really just want to point out on this slide, affect regulation. So maintaining your affect as a therapist in an 8-hour trauma therapy session with non-ordinary states requires a higher level of skill and different skills than some standard kinds of therapies. So that's an important aspect for therapists to maintain training and competence in. So let me spend 2 minutes here. I wanted to share, some about culturally informed care in the racial demographics of MDMA-assisted therapy studies continue to become more diverse over time, but there really has been a lack of solid representation of Black, Indigenous, and people of color. And we've also done, other demographic analysis around, gender and sexual orientation and other demographic features. And there's a long history of that with recruitment and clinical research and trust of the medical establishment. But there was a group of researchers, Terrence Ching and Monica Williams and several others, that did a sub-analysis of 2 of the phase 2 trials to see of the BIPOC participants that received MDMA therapy, was there a difference in their PTSD CAPS-5 scores? And what they found in this sample size of 20 BIPOC participants that received MDMA therapy and 63 non-Hispanic white participants that received MDMA therapy was that there was no significant ethno-racial difference in the CAPS-5 PTSD score change. We do want to work on developing cultural competency as a mental health field, as a clinical research field, and definitely with psychedelics. And the way to do that as practitioners is to, examine one's own privilege and gain familiarity with other identities and cultures, to not rely on clients to educate us about their culture, and to practice respect for different value systems and awareness of the power dynamics that additionally can be added because of culture, privilege, race, identity, sexual orientation. Being informed about the impact of racism, sexism on and other discrimination on psychological well-being, and being informed about the cultural perceptions and taboos about mental health, clinical research, diagnoses, the medical establishment, psychedelics, taking substances, etc. So the way that we provide culturally informed care is we inquire about and integrate the participant culture into the therapy. We open a discussion about culture and identity, demonstrating that we care and want to know and that it's important and it does have an impact on therapy. We address microaggressions if they happen in therapy, as well as our own implicit biases. And then working on inclusion of diverse populations in this therapy and in clinical trials, which includes everything from the physical setting to the language that we use and adapting our theoretical orientation to be respectful of various religious and worldviews. It includes the demographic makeup of site staff and how representative they are, as well as the resources needed to participate in clinical trials, such as time, time off work, time away from life responsibilities, transportation support system, and addressing barriers to treatment, including economic, physical, cognitive, and cultural. We're doing training for communities of color. We hope to do more. And I'll just leave us with, there are clinical trials underway with psychedelics. In the US, you can find out about those at clinicaltrials.gov. The results of the MDMA PTSD phase 3 trials will support a new drug application to the FDA to evaluate whether this treatment can become a prescription medicine. There's many training programs offering training in psychedelic therapies. This is just a few of them. And there are several national initiatives underway, including just in the last week or two, a letter from SAMHSA, the Substance Abuse and Mental Health Services Administration, about their intention to set up a federal task force, which will be an interagency collaboration in preparation for what they describe as new psychedelic medicines coming down the pipeline. So thank you so much, and I'll hand it back over to Jeff.
Outstanding, Shannon. Thank you so much. Again, really well framed. I think a lot of practical parts and pieces that a lot of clinicians want us to know about. Also addressing cultural diversity amongst training options, patients, patient care, and identifying some of those differences amongst BIPOC populations within the trials. So appreciate that. I'm reading lots of great questions. So I'll invite back the other presenters. So the three of you and myself can be on screen and be seen. And we've got about 15 minutes or so before we have to sign off. Before we start diving into some of these really terrific questions from our audience members, we do have a part 2 and a part 3. We intentionally, purposefully focus mostly on MDMA today, with the ideas of focusing on ketamine and also psilocybin in 2 later parts. So look, be aware and look at our site and go to our mailers and see when those are going to be posted. So just wanted to plug that early before people drop. We had a pretty consistent attendance, about 100. We kind of hovered around 100 all day, which was great. And this will also be available for viewing later on our YouTube channel. So I'll go with some small questions quickly, and then we'll get into some of the heavier questions. Can MDMA therapy benefit those with schizophrenia? Does anybody want to tackle that or talk about how that has or hasn't been studied?
I guess, oh yeah, Dimitri, go ahead.
I'm happy to take that as I'm a psychosis specialist. So thank you for that question. I'm really fascinated by that question. Briefly, people with psychosis are typically excluded from these trials and psychedelic research, other trials too, like for example, for psilocybin. So we don't really know. And researchers that I've spoken to privately indicate that there's concern about possibly exacerbating psychosis, and they really want to focus on these conditions first: PTSD and MDMA, depression for psilocybin, and they don't want to basically risk it, which is understandable. And the following is just my opinion and my read of the literature, not necessarily MAPS, but from what I've seen in the literature, there is some case reports of MDMA triggering psychosis, but they're pretty limited. It tends to be recreational use. We don't really have good research, I don't think. There's some anecdotal findings from people with psychosis saying it was beneficial to them. There's some older research suggesting it as well. But yeah, we just need more research, basically. There is a concern because it's a stimulant that it might exacerbate psychosis.
Mm-hmm.
In my opinion, I think it needs to be looked at. We shouldn't rule it out. We desperately need better treatments for people with serious mental illness.
Mm-hmm.
But I think we'll have to be really careful and start with like an observational study to ask people with psychosis who do use it recreationally how it affects them, and then very, very careful studies after that. And move toward possibly looking at it therapeutically. But yeah,
Okay.
We just need more research.
Of course. Okay, thank you for that answer.
Sure.
Here's a good question, I think, for everybody. Maybe it's just a resource issue, but attendee asked, where can you find practitioners, right, who are trained appropriately for these therapeutic approaches in the community? So this is kind of a good question for everybody. How do we plug in patients to these types of practitioners?
Yeah, maybe I can take that. So right now for MDMA-assisted therapy, it's limited to clinical trials. So in the US, the best resource to find out where there's a local clinical trial is that clinicaltrials.gov resource. And if you just type in MDMA therapy, you should find which ones are recruiting at this time. Unfortunately, this treatment is still under investigation, and so it's not legally approved for treatment. We're working towards submitting our new drug application for the FDA to evaluate whether this can become approved.
Okay, that's very helpful. Thank you. I think this may be a question for Allison. How can clinicians be a part of or support psychedelic assisted therapy? How can we participate or be supportive of political measures to improve viability, accessibility of these types of therapies, such as supporting SB 519? California, how can we best navigate being supportive, harm reduction for peers who want to explore MDMA therapy, but the peers do not trust the clinicians who don't have that access? So kind of a couple of questions in there, a couple of layers of questions about how to be supportive and then how to, in our community, and how to be supportive of peers.
Yeah, absolutely. So I started my presentation talking about our parent company, MAPS, the nonprofit, and they're really dedicated to creating the context for this harm reduction and working on these policy initiatives. So I really encourage you to go to maps.org and look at our website and some of the initiatives that are they're working on.
That's perfect. That's great. I think this question is going to be for you, Shannon, and anybody else. I haven't been saying names of the questions, so I'll just stick with that. But there's a registered nurse, a woman of color. She's noticed a severe lack of diversity amongst practitioners and therapists working in psychedelic-assisted therapy and in the research itself, while most of them are white-bodied men and women. With regard to cultural sensitivity and informed care, inherent colonial systems of oppression, and a very recent history of BIPOC exploitation, combined with the existing power dynamics of therapy and client relationships. She is curious to learn, how can we address this inequity, and how are you all working to cultivate more spaces where practitioners are representative of our greater communities?
It's a great question. Thank you, Diana, for that question. Yeah, a few different things. One is to point you to a resource on the MAPS website. Again, our parent company, maps.org/health-equity. And we've started a fund to be able to make MDMA-assisted therapy, either in the clinical trials or training, more accessible, especially to underserved populations and people of color and different, non-heteronormative populations. And so those funds go towards scholarships for therapists of color to receive training and to be considered, for work on clinical trials and approved settings to deliver MDMA-assisted therapy. They also go towards a treatment access fund. So MAPS has been supporting an expanded access protocol, which is kind of a bridge between research and real world practice. It is still registered with the FDA and follows a strict protocol. And that's kicking off at the time being right now. So the Treatment Access Fund helps patients who don't have the financial means or who have been historically excluded from therapies to be able to financially access this kind of care. And our intention is to be able to continue supporting those resources if and when MDMA-assisted therapy gets approved, because we don't want, treatment costs to be exclusive. All people deserve to access treatments that are available. And so we've gone from, in the MDMA therapy training program, we've gone from, very predominantly white. I think just 5 or 6 years ago, we were close to 90% white, which is admittedly embarrassing for me, to now our, trainee population this year includes 30% BIPOC therapists, clinicians, and counselors, many of whom are receiving financial support to participate in training programs through the Health Equity Scholarship with MAPS. We have a lot of work to do, and those are some of the initiatives that have taken place.
It's great to hear that it's on the radar and it's being, it's sort of being dealt with, and there's actions and motion and movement to make that happen. So that I'm glad. So thank you for those questions and appreciate that response from you, Shannon. We had a question about, is there a validated measure of inner healing intelligence to assess a person? I think Dimitri was talking about inner healing intelligence, and it piqued one of our participants' interest.
That is a good question. I'm not aware of one, but I love this idea. Something to pursue.
Okay. All right. Thank you. Let's see here. I may have missed the age range of participants. Any thoughts on traditional age youth 18 to 25 years old for this type of treatment? Potential pros and cons. And anecdotally, I think there would be curiosity and openness, although with the caveat that I am their primary therapeutic exposure, BIPOC Latino male, working primarily with low SES youth experiencing homelessness. What are your
Thanks
thoughts?
so much for the question. The transitional young adult population is definitely of interest. Our phase 3 trial recruited people that were 18 and older, but on the margins, you do tend to see smaller populations. So we're really interested in looking at this data pooled with our second phase 3 trial, which is ongoing now, so we can get a larger sample and be able to really report on what we're seeing and if there are any differences in this age sample, but it's definitely on our radar to look at.
Okay, that's great. That a follow-up question was, are there any studies of MDMA treatment for younger children?
So yes,
okay.
that's not currently ongoing. It is an agreement with the FDA after we submit our NDA that we will execute a pediatric development plan. So that's forthcoming.
Okay, terrific. Are there sessions used for complex PTSD trauma? Somebody said they may have missed that earlier on. So does somebody want to tackle that? For complex PTSD trauma? Are the sessions that we're offering?
Yeah, I could say, yeah. We've had various phase 2 studies that looked at different subpopulations within the PTSD indication. We have had phase 2 trials that did specifically look at chronic. We've had phase 2 trials that looked specifically at treatment resistant, where someone had to have failed to primary treatments, whether it was therapeutic or pharmacological. And what we found when comparing those was that there was no significant difference in those populations in terms of safety and effect data. Right. And so our current studies include both chronic and acute, developmental and complex, and some people who have treatment resistant and some people who may not have necessarily met that qualification of failing 2 previous treatments.
Excellent. Thank you very much. A question about, are nurses considered to be part of psychedelic interventions? Because mostly we talk about therapists and we talk about physicians. So is there a role for nurses?
Yeah, we love nurses. You know, so in the clinical trials that are happening currently, what our requirement for qualifications is that we have a co-therapy pair. So there's actually 2 practitioners in the room at all times for all sessions, and one of them must be fully licensed and within the scope of their license permits psychotherapy. So the psychiatric nurses that have that specialty tend to have that scope. The second person needs to have a sufficient amount of training in behavioral health and a scope of practice that allows them to be an adjunct, co-provider with the therapist, and that can include nurses. We don't yet know what will be required when the FDA evaluates this treatment to become approved. That will be a negotiation with regulatory agencies in terms of which practitioners can work on that protocol.
Okay, perfect. We have about 5 minutes left, so I kind of want to focus on something that hasn't been asked or raised is, how do we deal with the stigma around MDMA, right? When you suggest psychedelics for treatment, people's eyebrows are raised and they're curious. Besides the evidence, which we're demonstrating, and it doesn't have FDA approval yet, so trials are still underway. But how do you approach clinicians, physicians, nurses who maybe are, suspect of the efficacy or the usefulness of MDMA for treatment. That's for everybody.
I can speak to that a bit. There's this term that we call coming out of the psychedelic closet that applies here. And I think by having events like this and by being science forward, you know, the data are the data. So I know I approached this when I started sharing with my colleagues that this is an area of interest of mine. And sometimes things are changing and people are more open-minded, I think, but there were a few that had this kind of negative reaction, but I knew they were academics and, you know, very big on evidence-based therapy. So I shared the research, and I offered to give talks here. For example, I gave one a couple months ago to our PTSD seminar. And I think just, you know, that's one way to do it. Just sharing the data.
Absolutely.
I'll add just another thought on that. Yeah, which is really, that's why research, you know, is so helpful. In addition to that's the pathway of drug development, that it just provides an evidence base for us to start to understand, you know, and of course, research has its limitations in terms of demographics, and it's a relatively, you know, small sample size compared to the general population.
Sure.
So with those caveats, but just to be able to show, you know, published evidence. And it's been amazing to see some of the people we're now collaborating with and are now hosting clinical trials with MDMA-assisted therapy, like Bessel van der Kolk and Rachel Yehuda from the Bronx VA, and you know, Barbara Rothbaum from Emory. So just, you know, the evidence has, you know, risen to the attention of prominent researchers.
No, that's terrific. Yeah, I think that's very effective. And those are all VAs. Yehuda and, well, Bessel's got his center, and Barbara Rothbaum. Yep, that's terrific.
And then I'll just lastly add to that, this piece of it, as we're collecting data, one of the important things is that we can do it in a controlled setting. And so, especially with this treatment, set and setting are very important. The product is important. So when we're looking at, you know, unregulated use in the public, we're not looking at the same product. They are of unknown purity and may contain other substances that could be accounting for some of the symptoms that you might see. And it doesn't have a regulated set and setting, which is really key to the therapy. And I hope that if everybody walks away with one thing from our talks today, that the MDMA, it's really MDMA-assisted therapy. It's not just MDMA. So
no, I think that's really illuminating and important to walk away with. I want to wrap up by personally thanking all three of you. This was, I thought, a fantastic set of talks and great questions and a very interactive audience. So I want to say thank you for that. If Nat, you can just show those last couple of slides. I want to say thank you to the executive committee and our staff from the USC Institute for Integrative Health and Wellness, and Dean Varun Soni at ORSL, and of course the Center for Mindfulness Science. Dr. Rael Khan and I had discussed this and talked about partnering to present this, and we're looking forward to presenting the part 2 and part 3, which you can see on the last slide here. So please pay attention to the announcements, or please sign up for IIHW or CMS for their listservs, our listservs, and be part of our community so that we can all sort of rise together in this evidence, leaning forward with evidence and science, as Dimitri said eloquently. We need to lead with science. And I am very grateful and very appreciative of all of you today and taking this time to come be here virtually with us and with our USC CHLA communities in Los Angeles and beyond, for those of you who signed on. So thank you very much, and look forward to collaborating again really soon and working together to improve health and mental health for our patients and families in our communities. So thank you very much.
Thank you so much for having us.
Thank you all so much. Thanks for being here.